Hello, doctor. How are
Hey,
you?
Fran, how are you? Can we
Great.
start the recording before the lecture, or do you need to start it right now?
Yeah, no, I don't know. It went automatic and actually it
Yeah,
should,
tiene the setting
it
is
should.
You.
Oh,
I'm gonna
oh,
start the recording because we can just edit it out so we don't forget.
oh, I see. You could just cut it out.
Yeah.
Okay,
Last time I paused it, we forgot.
got it, got it. And so, doctor, we already have a couple people that are on, so they're a little early. We have a couple
okay.
of early birds already logged on.
Yeah, I just need to add the picture that I got yesterday. I mean today.
Wonderful.
Give me 1 second.
That doesn't look like your office.
No, I came, I went exercising, I went cycling, and then home
Nice.
early.
Good workout before. Exercise. That's something I have to remember to start doing again.
I definitely worked out before this too.
Oh, all right. Good for you. Both of you.
Nope. No, that was a joke.
Two out of three.
You should have seen my setup in I did the recording in our entryway. And so because the background is white and it's easier to lend to like social media like backgrounds and stuff like
Oh, I
that.
see. Yeah. Right.
And so
Yeah.
it was like in our entryway, and I had like a bench set up with like another table on top of it, and then a can like a big decorative can thing on top of that, and then the
Yeah.
computer on top of that. I was like,
Right.
this
Yeah. Like
is
a
this
pyramid.
is an accident waiting to happen.
Well, at least you didn't do it on a stairwell. That would be like adding
Yeah.
the next level to that. Well, thank you.
And I should have took a photo of it.
Yeah, but no worries. I'm looking forward to checking it out, taking a look as soon as I log on.
Did you? I mean, Tara
So
told you the
yeah,
whole.
yeah, that's great. Yeah, so our
Yeah.
our old uh Facebook is back on.
Hmm.
Awesome. Good, good,
Yeah.
good. A previous version. Yeah, that's great. Okay.
Yeah, because with a professional page,
Mhm.
um, you can't request people; they have to follow you. So it's a lot harder to build, you know what I mean, than like a private page. Like my true function, my personal true function, or like my Trisha page is like I could just request people. You know what I mean? Like if I meet
Yeah,
people, I can request them. That's not the option with a professional page. So it's a big deal to have that back.
right on.
Yeah.
Awesome.
Like Angela just logged on. I don't know if you know Angela, but hi, Angela.
Hello, Angela. So how's the weather in Indiana?
It was warm today. It's been like in the like low 70s, 60.
Oh,
But
that's
today it was
pleasant.
81. It's supposed to be 80 through the weekend.
It's warmer
So
than here. We're
really?
we're in that range. I think
Yeah.
you guys got us this summer. I think it's warm. It's been warmer in Indiana than San Diego. We had,
Definitely.
we
Yeah,
had a
based
few hot
on
days, but yeah,
yeah. Although our temperatures are different.
you
Because
get
like
humidity.
no like no, like when I was there, everyone's like, it's so hot here, it's so hot here. And I was like, this is gorgeous.
Weird, huh? Because we can't. We're wimps in San Diego, so we could.
Right. You guys don't do fluctuation well.
If it's like below 55 degrees, we can't handle it, and it's
Right.
above 85, we're in trouble.
Right.
Don't let it
Right.
rain because that's a whole other mess.
Right. No, I think it was the look on Marco's face. I think it was Marco when I was like, "Oh yeah, I mean, it's nothing to hit negative in the winter, and we've hit over 100 before in the summer. You know what I mean? So
Yeah, quite a
it's a lot different. It's a lot different than there.
Yeah, we are probably within, I don't know, I'd have to look, but probably within 30 degrees, top to bottom.
That's like a day. That's like one day here.
Yeah.
Literally, it was 50 some when I woke up, and it was 80 by this afternoon.
Okay. Yeah.
Dr.
Hey,
Correa knows all about this being in Boston,
about the weather? Oh yeah.
the fluctuation of weather.
So
I wish I was going on vacation with you guys. Can I just meet you there?
Yes, come on down. Come on down.
I'm sure Allie would love to show me her restaurant. So
Allie would love to have you, that. She'll take you to that special restaurant she likes going to. So
I know, I heard all about
it. She tells everybody she meets, she wants them to go
to go there.
Yeah. She wants to it's the funniest thing too, because she takes her a while to get comfortable with getting up there.
Yeah, that's what you said.
But yeah,
I'm offended though that now you told me she tells everyone. I thought it was special, and she's
everyone that's special. There's like 2 people that I know.
I was just thinking about what time is soccer?
We have soccer practice at 5:30. I've already let them know that I'm gonna be a little late, so we're good. Yeah.
Okay. Maybe we should talk about days of the week for webinar. Mix it up, because other people might not be available on Wednesdays either.
Sounds good. Yeah.
You know what I mean? Like maybe docs have late Wednesday nights. You know what I mean? So mixing them up sometimes might not be a bad idea. Maybe do like a Tuesday or something in the future.
Awesome. Yep. And plus, when we're like doing webinars for Europe and Asia, we're gonna have to modify our times too.
He's not paying attention.
What's that? Oh,
you're talking about with Correa.
Yeah. The coolest thing about we're talking shop now, but the coolest thing that we're finding with that new EMA is right on. Okay. Typically with EMA we have to be really mindful of retention on cases, and what we're finding with the digital process, we're able to improve retention. So some cases that we might reject, we're actually able to make, which is really
awesome.
Yeah.
I was talking to a doc this afternoon, and he has had an EMA, he said, for like over 4 years, and he is like, it's been great. He's like, but I think I need an upgrade. And he's like, but I can't get, like, I love that design. And I was like, we have a milled one now. I'm like, a milled one. And he's gonna order that for himself.
Right on. Yeah. Yeah, it's nice stuff. Yeah. When I first, this was a couple years ago, we were introduced to it, and we were doing some trials. I was like, I don't know about that. And then it's like we started to get some feedback, and it, yeah, turned out to be a really good product.
Yeah. Yeah, I think that EMA that we were talking about the other day, we should try to do that material instead. We can talk about that later.
Cool.
I don't want to say a patient name that's not HIPAA compliant.
Oh, that case. Yeah, yeah, yeah.
Yeah, you know
Yeah,
what I'm talking about.
we can try it. I'm definitely open to try that. That would be a challenging one, but
Yeah.
you know, it's worth trying. Yeah, it's worth trying.
They're sending information back.
Yeah, you know, that stuff is it's the texture from the printed models, so it's really not a bad thing, but you know, aesthetically, it's probably not.
Mm.
Yeah, because you know how the 3D printers build in layers, so
Mm-hmm.
you can see those little layer lines, you know,
Mm-hmm.
in the appliance. That's all that is. Yeah.
I know you were talking about hands on deck today, and I was like, I wish I could help you. I'm
Oh,
like,
well,
can I just become a tech for like an hour a day?
I know.
Like, I'll just pick up, Jeanette, a couple days a week when you need extra hands in the morning for like 1 hour before you get in, just to
Yeah,
prepare you for the
exactly. That
day.
would be either a little bit early or a little bit
Yeah.
late. Probably a little early would be better. Yeah. But we're making it work. It's basically just shifting, you know, team members. Yeah.
Yeah. Right. Right.
Sometimes we just have to like have the discussion so we can all, you know, kind of all the brain power and
Yeah.
and come up with solutions.
I'm gonna have to learn that process though.
What's that?
I'm gonna eventually have to learn that digital process
Yeah,
though.
yeah, exactly. Yep.
One of the like I think you met when you were at the Las Vegas lab meeting, you met
Mhm.
Brooke and then another professor. I think they were both there, but I think only one spoke to you.
Yeah,
The other one, like she just messaged me last week and asked like how I was doing and what was going on, and I'm like, I'm in the lab world, because I hadn't spoke to her since like last time she knew I wasn't in the lab world, that type of thing.
yeah.
Like right out of college. And so, but she said that she left the school. So I don't know what they're doing for professors.
Well, what's she up to?
The main like Brooke that you met is still at the school. She was the like one was the director and one was the like just like the lead, I guess lead, or kind of like the other main professor. So and I'll have to reach out to her and see what's going on. The other one.
Yeah, Janelle was telling me, I was asking her about school, and she said that you know, of the group that went to school with her, just a small number continue to be technicians. Others went out to do other things. I'm like,
Mm-hmm.
great.
Yeah, no, that's the same. That's the same with me. I have like a handful of them that I know of that aren't like doing dentistry at all. Um, One of my best friends that was in the group is an ortho assistant, so she's not really even. I mean, she does a little bit of odds and end lab work, but she's an ortho assistant. And a lot of them right out of college went to. I don't even know exactly what it was called. Like, what's the like Invisalign but direct to consumer that is the hot mess? I'm just kidding. I don't know. I don't
Oh,
know.
Smile Direct Club.
Smile Direct, yeah, because they were like hiring people to just work from home. You know what I mean? And
Yeah,
so
yeah,
I think a
interesting.
handful of them ended up doing that.
Makes sense. Dr. Correa, when you're ready, just let us know. What I'm gonna do, if it's okay, I can pop up some scans and kind of just talk about some of the stuff that I see in the lab while you get going. if that's okay.
Yeah, whenever you're ready to share your screen.
Yeah. Cool. Yeah, I'll do that. So I can bore.
Please, can you send me the slide that you sent me before? And I have the presentation open. I just need to copy and paste it. There wasn't a slide that we want to transition to you after I
Oh,
finish.
for
To have
the
continuity.
one Tara sent you? Yeah.
Yeah.
Let me get that over to you. Was I in that? Okay, it should be in your email.
Okay.
Trish, would you allow me to share?
Yes. All right, and everyone that's
I'm almost
joining.
done. I just need to put one more slide.
Awesome, Doc. Yeah.
Everyone who's joining, we'll get started here shortly. We'll give it probably another 10 minutes and we'll get started. So hang tight. You're on mute and your cameras are turned off on purpose. So we'll get started here shortly.
Excellent. Doctor, let me know when you're ready and I'll get out of your way. I'm just going over, Trish, you can see the scan here, yes?
Mm-hmm.
On the screen. Awesome. So I'm just going over what the laboratory needs when it comes to a scan or an impression. We do ask for minimally 5 millimeters past the gum line all the way around. So this would be an ideal scan for a device. Of course, if you needed to do anything on the palate, full palatal scan, depending on the appliances that we make. But typically, we don't need the full palate if you're simply making an oral device for sleep. A palate would be more for a retainer type appliance. So let's see here. And I'm just going to show examples of different types of scans. In the meantime, let's see here. And here's a scan, I mentioned that ideal scan extends at least 5 millimeters past the gum line. In this case, obviously it's a little short. It looks like maybe the patient's tongue was in the way. So, I would ask that when you're scanning, got the patient in the chair, just double check the scans and retake, in the areas where possible. Not sure if this patient had a gag reflex or what, but, we weren't able to capture all the data needed for a properly fabricated device. And then here's another scan with distortion. So you can see here, the teeth look kind of, they got stuff all over the place, so sort of blotchy. That's possibly due to excessive reflection. So maybe too much saliva in the mouth or possibly some metal restorations in there. Hard to tell, but so this would not be an ideal scan. This would not be an ideal scan. Alrighty, here's another one. Whoop. Here's another scan with a super large cusp on that molar. That can't be right. Again, probably excessive moisture, excessive saliva in the scan. Just things to look out for. We have the extension we need, which is good. We just have distorted teeth. So there's a lot of texture on those teeth. That doesn't quite look right. And this scan here, looks pretty good overall, approximately 5 millimeters past the gum line. But what we do have, if you look at the incisal edges, see, this is where the edge ends, and we have like a superimposed an additional incisal edge there. And also we have like a hole here. And I believe that's called improper stitching, if I'm correct. You can see where there's a void on the upper. So yeah, that's a little bit of a challenge there. So this obviously would be a distortion, and we would not be able to utilize it for proper fabrication of a device. Anything you make on this scan would probably not fit. Okay, so let's see here. All right, and this is a set of scans for treatment positions. So typically, this might be more for a TMJ appliance than a sleep device. We don't quite have enough vertical between those cusp tips for making a sleep device. So this is probably like maybe some kind of a split. Again, when we're looking at it from the lab's perspective, we're looking at your scans not from cusp to cusp in this direction, but we're actually looking straight across, horizontally, how much space we have. So if we have, a palatal cusp that's hanging down and a buccal cusp that's hanging up, this is really the amount of space we have. It's less than a millimeter. So they're just things to consider when you're taking scans for an appliance, is understanding how much space you have available. Don't just look in the front. When you're placing your George gauge or any type of device for taking a bioregistration, understand what material you'll be utilizing, and then also know how much vertical is necessary in order for us to accomplish a proper appliance. And of course, the laboratory can guide you with that. So we're totally happy to help. Very happy to help.
For those of you that are just joining us, Frank is just talking about scans here. We'll get started on the full webinar in just a few moments here, give you a couple more minutes for everyone to join. So Frank's just chatting about scans. The webinar hasn't started yet. We'll get started here in just a moment. Frank's just sharing tips.
Tricia could have said, "Oh, you guys just missed it. It was a wonderful webinar."
Everyone have a great day.
Just kidding. Yeah, we were just going over some different types of scans and what we're looking for, and also some distortions in scans. So we have a few examples of different types.
I'm getting some questions, Frank, if you want to answer
Sure.
a few.
Yeah, certainly. Yep.
Do you still mount on AccuLiner for TMD and sleep appliances, or do you feel like it's no longer needed?
That is more of a clinician preference. Some of our clinicians feel strongly about using the AccuLiner, and we're happy to do it for you. So that's really more your preference from the clinician's perspective. We're happy to do whatever you like. Hopefully that answers your question.
And the next question is, do you offer a variety of materials for TMJ? Yes, we do. The great thing is if you go to our website and go to send a case, there is a materials list there where you can see all the materials that we offer. You can see all the TMJ appliances that we offer and what materials go along with those are available in those designs. So that's a great resource to figure out, what materials, what's the benefit of those types of materials. So definitely take a peek on our website at some of that information.
Awesome.
You look beautiful.
Looking sharp, looking sharp.
I'm gonna go ahead and share your screen.
Have I unshared? I've unshared, right?
Yeah.
Oops. Okay, good. Wonderful. Awesome. Great.
Alrighty, everyone. We're just gonna give it just a couple more minutes here while we're getting the PowerPoint set up. Let a few more people join. You are on mute and your cameras are off on purpose. So we'll go through those logistics here in just a moment.
So, Dr. Correa, where are you headed next? You're always traveling.
Hello, everyone. Nowhere. So I'm grounded in Boston for the next week or so. Just kidding. No, for the next month.
For the next few days. For the next few days.
days.
At least hours.
No, I think it's interesting because traveling and going to different places. That's the way that we can share all this information with so many dentists with interest in this field. Also, I think it's nice to make friends, make new colleagues, new people with the same interest, the same passion about this field. So I'm very happy that I have the opportunity to do these different trips around the globe.
Yeah, that's wonderful. And I know sometimes we are in communication, and you're in a whole different time zone, not just time zone, a whole different part of the globe. So it's pretty amazing how much you do for this community, for helping patients and helping to get the word out, and that's certainly appreciated and admired. Thank you. So, Doc, before we get started, I think, well, no, I think we'll start whenever you're ready, Trish.
So right now, are we like in the panel side or with participants?
The participants are on.
Oh, hello.
Yep, hello. Their cameras are off, and we'll go ahead. I was just giving it a couple extra minutes here, so I'll go ahead and get started here, and then I'll pass it over to you guys.
Okay.
Awesome. Yep.
Alrighty. Alrighty, well, welcome everyone. Thank you so much for joining us today. A little bit of details on Zoom before we get started. Like I had mentioned, your cameras are off, you are on mute. We will open the floor up for questions at the end of the webinar. So don't hesitate to utilize the question and answer box throughout the webinar, or at the end, of course, we can unmute you so you can ask those questions and have a conversation with Dr. Correa. The best way to view the webinar today is up in the upper right-hand corner. There's going to be a view option, and you can click speaker view. Now that speaker view is going to give you the side-by-side of Dr. Correa and Frank, as well as the PowerPoint. So that's the best way to view the webinar today. The webinar is going to be focused on the management of snoring and sleep apnea with oral appliance therapy. So you will receive a promo code at the end of the webinar, so definitely stick around for that. We'll have two speakers today. Frank, we're going to start here with Frank. Frank started True Function in 1999. He began as an RDA and has been working with the lab for over 30 years. 20 of those have been strictly dedicated to sleep and TMJ. Frank has spent many years in research and development, creating workflows to create and digitize our appliances. So he's a wealth of knowledge on all things oral appliances and working alongside clinicians to help with troubleshooting. I'd also like to introduce our dear friend here at True Function, the Associate Professor and the Director of Craniofacial Pain and Dental Sleep Center at Tufts University School of Dental Medicine, Dr. Correa. So Dr. Correa is committed to supporting academic learning as well as clinical practice and has worked as a faculty member at Tufts University Craniofacial Pain Center for over 20 years. During this time, Dr. Correa has worked alongside the faculty members to maintain the highest level of excellence in patient care and patient-side training for residents and dental students. Dr. Correa is an active member of the professional associations such as the ADEA, the ADA, the AADSM, the AASM, and the WSS. He's a diplomat of the American Board of Dental Sleep Medicine, a fellow of the International College of Dentists, and a visiting professor in different dental schools. Dr. Correa has incorporated the teaching of dental sleep medicine into the pre- and postgraduate programs and has developed various CE programs through Tufts. His international reputation holds is evident from the multiple well-attended continuing education courses, which he receives overwhelmingly positive feedback. These include the temporomandibular disorder mini residency, the dental sleep medicine mini residency, the dental sleep medicine comprehensive introduction, and the pediatric dental sleep medicine mini residency. He also has been invited to present at institutions across multiple continents, as Frank had mentioned, including North America, South America, Europe, Asia, and Australia. So Frank has been working closely with Dr. Correa and Tufts for many years, so we're honored to have him joining us today for our webinar series. And Frank, I'll pass it over to you for the rest of the intro.
Thank you. Yeah, just a couple brief words, Dr. Correa. Thank you, Trish, for the wonderful introductions, by the way. Dr. Correa, just wanted to express our gratitude for your friendship and your support in doing this webinar for us. We know you're extremely busy, and so really value your time and you know, the information that you'll be sharing. And it's a blessing to have you. Thank you.
No, thank you. Thank you so much for the invitation. Thank you, Trish, for the nice introduction. And of course, I think the last several years, so we've been working together in different areas, different places. So it's really, you know, nice to see familiar faces and understand that through this wonderful field of dental sleep medicine, so we can collaborate. We can collaborate with different institutions and of course different corporations. And I know True Function is has been part of the making of this field and connecting many peoples in the US and different places. So today, what we're gonna do, you know, we want to keep this this webinar interactive. So I know the question answer will be towards the end of the presentation. But you know, I think the way I put together this slide is to understand a couple of things. To understand what can we offer to our patients, you know, from the standpoint of screening and treatment options, and also to understand the different designs of oral appliances. So very often the big question is, you know, what appliance I'm going to use. So what appliance is going to, you know, to work better in this patient or the other. So the reality is that oral appliances are needed. It's the tool that we're going to use to manage to treat the patient. However, I think it's important to understand patient characteristics. So what are, you know, the dimension, the size of the maxilla, condition of the dentition? Does the patient have any TMD, pre-existing TMD symptoms? So what are the characteristics of the patient to understand, you know, what appliance design, what material of the appliance will be utilized? So we will try to cover as much as possible during these webinars. And of course, I mean, there are an extensive number of continuing education courses at Tufts University and many other places that every single course, every single program, it really offers a value of understanding different clinical approaches, different information. So I encourage all of you to look and, you know, to explore what is there and to take the best from each of these programs. Just to begin with, so I do not have any conflict of interest, no financial relationship with True Function or any company, and I'm not receiving any honorarium for this webinar. It's mainly to share with all of you about this important field. So when we see about this option of therapy for patients with obstructive sleep apnea, so very often the sleep physician, you know, try to find the dentist with knowledge, with training, with some capacity to offer this this treatment modality. So the steps that we follow, though, this is part of the standard clinical protocol that we follow in the clinic and the one that we teach in different places. So, and it's very straightforward. So what we need, I mean, we need to start with some type of a screening to understand maybe many of the existing patients in the dental office already suffer from chronic loud snoring or obstructive sleep apnea. So there are different tools, different screening questionnaires that will help us to identify this particular group of patients. So now the next thing that we see here is about the referral and diagnosis. So what are we going to do? So what we want to do is to develop this collaboration with the ENT, with the sleep center, with the sleep physician, just understanding that obstructive sleep apnea is a medical condition, can be treated from the dental standpoint. In this case, we'll focus into oral appliances, but we need to establish that collaborative approach with the medical field. So in that way, the referral process, the diagnosis, and, you know, some complex cases that we may encounter, so they will be easy to manage with in collaboration with other colleagues. So after we complete all the process of diagnosis through the sleep study, of course, so there are different types of sleep studies. The gold standard at this point is the polysomnogram. The polysomnogram is when the patient is spending the night in the hospital, and there is a series of sensors placed around the body to detect or to record different parameters during the sleep. So after we get that diagnosis, to understand the severity of the condition, if the patient is mild, moderate, or severe sleep apnea, so we need to perform a comprehensive examination. So what is the comprehensive examination? So basically, it's to gather the information regarding clinical history, medications, medical history, examination of the masticatory muscles, temporomandibular joint, occlusion, and the overall component of what we need to understand from the patient characteristic standpoint. So from there, it comes the step of oral appliance selection. So currently, there is a very large number of oral appliances in the market, different brand names, different companies that are, contributing each time with new designs. So this is very it's sometimes a little bit complex because oftentimes, depending on where you live or what country you live, but there are some limitations in appliance design. We have the privilege here in the US to have a variety of appliances design that we're going to review today, and the ability to communicate with different manufacturers like Fran True Function, the team used to, to select and to understand what is the best option for our patients. So from there, when we select the appliance, so what are we going to do with the appliance? So after we receive the appliance from the manufacturer, regardless of the appliance design, so we need to understand this important step, which is the settings of the mandibular position. This mandibular position is going to be obtained from the bar registration that we are going to take as the process to fabricate the appliance. So, but there are two mandibular positions that we need to achieve, that we need to understand. The first one is the initial mandibular position, which is the settings that you are going to share with the manufacturer coming from the bar registration. It could be 50%, edge to edge, comfortable position, whatever dimension, whatever position you are comfortable to start with, that is going to be replicated in the fabrication of the oral appliance. So you receive that appliance with the initial position that you provide from the bar registration. And from there, you are going to achieve the therapeutic mandibular position. So what is the therapeutic mandibular position? So it's the mandibular position that you achieve after several adjustments. It could be the adjustment can be done in the office, or you can instruct the patient how to do this adjustment at home. So it depending on what protocol you in particular want to implement in your practice. So as long as the patient understands how to do the adjustment at home, you can follow up with some phone calls or video conference just to understand if the patient is doing the adjustment in the right position. So basically, as a summary from this step is initial mandibular position, the one that is replicated from the bar registration, and therapeutic mandibular position, the mandibular position that is going to provide resolution of different things, resolution of snoring, improvement of quality of sleep, decrease of daytime symptoms, and just a series of signs and symptoms that we tend to encounter as a baseline. So we're looking at improvement of those areas. If the patient do not report getting better, if the patient continue having some condition that is not, you are not seeing the results. So it's very important to reassess, go back to the medical history, to the clinical history examination, and find out what is happening with this particular patient that is not responding to the oral appliance therapy. Communication back to the sleep doctor, or maybe a different type of therapeutic modality to be implemented. So after you achieve all these areas, so don't be surprised. Don't be surprised because at some point in the beginning of the treatment, at the end of the treatment, or when the patient returns in the long term, so you are going to encounter these potential side effects. So the side effects are going to occur at some point. at some point. And the side effects, I mean, it's unfortunately, it's a long list of side effects. However, the most common side effects that you're going to encounter in your patients include symptoms related to the temporomandibular joint, occlusion, tooth movement. So basically, those are the most common symptoms. There is, plenty of evidence and emerging evidence as well on the way that we can improve, manage, or sometimes, avoid this type of side effects. So the patient with sleep apnea utilizing the oral appliance is a patient that you are going to keep in your office for a very long time. So you need to establish these follow-ups in the short term, follow-ups in the long term. Currently, the protocol, clinical protocol that is recommended is after we finalize therapy, after the patient gets a second sleep study with the oral appliance to verify efficacy. So you schedule the patient at 6 months and eventually once a year. So overall, I mean, this is a quick overview of these steps. So this step that I mentioned is something that we developed at the center, and it goes into 10 steps. 10 steps that we do make it easier to understand, to replicate, and of course to teach to all of you dentists taking our courses at Tufts University or different places. So we try to implement and standardize this type of protocols, standard protocols. So briefly, I mean, what is the screening? What are the first step? Maybe some of you are in the early stage, or maybe you are looking to treat your first patient in your practice, or maybe looking to incorporate the field of dental sleep in your office. So what are you gonna do first? Well, I mean, you need to start screening patients, existing patients coming for dental appointments. So one of the things that we include on these screening tools are 2 validated questionnaires. So the first one, very, very common, is called the Edward Sleepiness Scale. So this sleepiness scale, the clinician, the dentist, which basically asks the patient 8 different questions related to the chance of dozing off, in 8 situations. So the patient will score from 0 to 3, the chance of dozing off, 0, of course, no chance of dozing, 1 mild, 2 moderate, and 3 severe or significant sleepiness. So if the patient score, the patient report a high score, so it indicates that, that is significant sleepiness, that there is a need to look for some type of treatment. So the second questionnaire, the second validated questionnaire, is called the stud band. So the stud band is very interesting because it includes also 8 questions, 8 items. But the difference between the stud band and the Edward Sleepiness Scale, so is the content of these questions. So in this case, we are looking signs and symptoms and risk factors in this questionnaire. History of question related to snoring, tired of sleeping, observed like gasping or choking for air during the sleep, blood pressure, BMI, which we know is an important risk factor for developing or worsening the sleep apnea, age, neck circumference, and gender. So it's a combination of risk factors and symptoms. And again, so it has been validated for the purpose to screen patients for obstructive sleep apnea. So now, as we look into this slide, though, so for the purpose of today's webinar. So oral appliances, it comes in different size, shape, not flavor, but colors as well, as we see in here. So today, I think, we will be able to answer some questions about appliance design, characteristic, material adjustments. So we'll go step by step in some of these devices. So let's review a few things. So what are we looking here? So we know that there is a large variety of devices, appliance design. However, we can see that it has been a long time since different groups, different people have utilized this type of devices. And it has been a long journey, though, from the development of protocols, development of different studies, and evidence, developing the evidence, scientific evidence, showing the efficacy of the devices and the comparison with other treatment modalities. So to keep everything in place, and as a kind of summary from the existing clinical protocols and guidelines, so we know that oral appliances, though, based on the scientific evidence, based on the evidence that we have, so we understand that oral appliances, they work better in patients with mild to moderate sleep apnea. So therefore, the guidelines, indicate oral appliances to be recommended in patients with a particular level of severity, so mild to moderate. However, there are some patients with severe sleep apnea that for some reasons, different reasons though, they cannot tolerate the CPAP, so they have to try some other treatment modalities. So in those cases, as long as the patient already tried the CPAP, so they can have a trial of oral appliances. So it's important to know that dentists who plan or dentists who already started doing this therapy with oral appliances, I mean, it's important to take some additional training, some updates on clinical protocols, management of side effects, because it's something that will provide better service, better treatment. Though it's easy to understand what is happening if the patient develops some TMJ problem or some type of occlusion, how to modify, adjust, or change the type of appliance design. So the purpose of these devices, of course, is to work by itself, to manage the obstructive sleep apnea by itself. However, an additional benefit that we have with these devices is that in some patients, it can be used as a combination therapy. So this combination therapy, it helps to, in this case, what we're looking at here is a combination therapy of oral appliance with CPAP as an adjunct to PAP therapy. So basically, the oral appliance, what it does, it opens the airway. It may, in some cases, severe cases especially, if the oral appliance do not eliminate completely the obstructive sleep apnea, so that residual apnea can be managed with the use of the CPAP. So, but what is the rationale of this? So, well, I mean, by doing this combination therapy, the CPAP will not require a high air pressure. It will be like a low air pressure, easy to comply, easy to tolerate for the patient, given the benefit, the full benefit of eliminating all the apneas, doing the combination therapy between oral appliance and CPAP. So looking into this slide, briefly, we can see that the comparison of different type of oral appliances. So we started with the tone retainer device. It's not commonly used, but there is some evidence, some studies done in this particular type of oral appliance, the tone retainer device. It's utilized mainly in patients who are edentulous or in patients who are in the process of getting some extensive dental work. So as a transitional device, as a temporary device. So the second one, we have the non-adjustable oral appliances. The same thing. So there is, in the literature, you will find information about these non-adjustable oral appliances, which is utilized in many countries, many places. And then, on the opposite side, we have the adjustable oral appliances, which are the most common devices utilized here in the United States. And for the purpose of understanding the function of these devices, we're going to review the nomenclature. What are the particular characteristics, the mechanism by the way the oral appliance is going to maintain the mandible forward. So we'll focus into that nomenclature. And this device is a single arch tone depressing device. There is some reports, some literature related to this particular design. So it's important to know that it exists, it's there. It's not heavily utilized, but again, so you will see at some point in some presentations or in some literature, so it's important to know this particular design. So what about the features though? For each of these appliances, you are going to look or you're going to see that they contain some mechanism. So this mechanism, as we see here, they must provide some level of adjustment. In other words, the mechanism can be adjusted at 0.5, 1 millimeter. The second one utilizes different bands that can be changed depending on the how much protrusion we want to obtain on the oral appliance. Some mechanism, some small hook that will help to push or to bring the mandible forward. Or the last one on the right side of your screen, some particular fins that will prevent the mandible to move back. Now, getting into the nomenclature. So we know that there is a variety, large number of devices. So let's review these 4 designs. Okay, so we're going to look at these 4 designs based on the attachment and proportion. And here we will have some interaction with Fran and myself. And again, so you can take notes of these designs, and we'll go over some questions at the end of the presentation. So the first one is called the bilateral compression based on the design and nomenclature. So what is bilateral compression? Well, this particular design, the bilateral compression, is a device that includes some adjustable rod-like components. And the thing to remember here to understand this term, this terminology, the nomenclature, is the location where the component is going to be attached. The location between the upper and the lower plate. Remember, all these devices, adjustable oral appliances, will need an upper plate and a lower plate, and then there will be some attachments. So in this particular design, the bilateral compression mechanism will extend from the upper posterior part to the lower anterior area of each of these plates. So this is how it looks in the mouth. These are different designs, okay, and they include these small increments with the adjustment on this small area. So that here we can see the different views of these designs. And of course, I mean, these designs are fabricated in different materials, and it's important to know the type of particular tools that are needed for the adjustment, and the specific areas that we're going to include in this part. So Frank, what can you tell us about this bilateral compression design?
Sure, Dr. Correa. So, in this image, we have the true herps. We have a couple different material options, and, no matter who you work with, typically they'll have traditional acrylics or digital versions of a herps device. And, a couple of good things about the herps is if in the US, they are covered by Medicare. So if you have Medicare patients, this is a product that is covered. Is a PDAC approved device. The other thing is, it does allow for lateral movement. So it does allow for the mandible to open slightly and for the patient to have a little bit of movement laterally. Yeah, again, different material options, different technologies. It can be a digital version, or you can have a more traditional version as well, Doc.
Thank you, Frank. And then we can see more, a few more designs. And from the bilateral compression, we move into the bilateral traction. So again, we're trying to get a sense of the mechanism, this particular nomenclature based on design and nomenclature. So now we have the bilateral traction design. So the bilateral traction, this is one of the original or the first designs that came into the market a long time ago. But a very good, nice colleague of us, though, which we see here during the meetings and so on. So the bilateral traction, it includes these particular straps, these particular bands. And once again, so how are we going to differentiate compression from traction? It's basically the location of the attachment, the location where the component, the location where the mechanism is going to be implemented between the upper and the lower plate. So in this case, the attachment, the mechanism, it will go from the upper anterior area to the lower posterior area, basically the opposite of what we saw into the bilateral compression. So this device, as we see here, this is a view inside of the mouth. And you may notice that like the bands, they have different colors. So we're going to explain in a few seconds what the color means, what is the reason for different colors, and on some small numbers on the size of the bands. So the fitting of these devices, I mean, the fitting description, so you need to hook, you need to include the band between the anterior part of the upper plate down to the posterior part of the lower plate. And now we can see this, with a very view, these particular bands. So Frank, what can you tell us about this bilateral traction design and, these different colors? So what will be the way that we will know what color to use, or how the dentist is going to receive this particular design when it's fabricated, when it's ready to be utilized in the patients?
Sure thing, Doc. Typically at True Function, most labs will make the device to your bite registration. So the important thing is making it, taking a great treatment bite. And so we would make it typically with a 21 millimeter strap. So the longest strap possible available for the device. As Doctor mentioned, there's different elasticities. We typically go with the blue, which is a firm. And the reason we go with it is it has enough elasticity. It's not super rigid. It allows a little bit of comfort for the patient. The softer ones may give a little bit too easily, and you may lose position. So just something to consider. You might need them for certain patients. That's more from the clinical perspective, but typically we find that the blue is a good option. The one thing to think about is when you're taking your bite registration for this device, the EMA is, although we have a large variety of lengths, I would keep it within 3 or 4 millimeters of maximum protrusion. In other words, when you take your bite, try not to take it too retrusively, because it would take, the shorter the straps, the greater the possibility of the device dislodging. So, if you have a strap that's very short, it's going to tend to dislodge the lower tray for the mouth. So something to think about with when you're taking your bites for these.
Fantastic, thank you, Frank. Here we can have we can see different views of the design as well. So the component and the small extension of the hooks between the upper and the lower. So another view, and we can see now this particular picture. So it has a different color. This is a clear elastic. So the clear elastic is the strongest one. In some patients, especially with significant grinding though, if they tend to break the bands that you provide, the yellow, the blue, then the clear elastic could be a good option though to avoid this situation of breaking the bands too often. The other thing that we can see here in this particular picture is 2 small hooks and the upper and the lower. So when are we going to utilize, or when do you need to request these particular hooks? Well, I mean, when you send the impression, the digital scan or the analog impressions to the laboratory, so you need to indicate if you are going to need these hooks for elastics. And what is the reason for this hook for elastic? Well, this hook for elastic, it will prevent for the patient to open too wide during the sleep. So if during the initial examination, again, we need to look into the occlusion, range of motion, temporomandibular joint. So patients with a significant range of opening, 50 millimeters or more than 50 millimeters, you need to think about the oral appliance that will not allow to do that excessive opening during the sleep, especially if the patient tend to sleep in supine position, because if they have an oral appliance that do not restrict the opening, so what is going to happen? So it's going to open wide, the mandible is going to drop back, and it will not maintain the efficacy, the position, the therapeutic position that we are looking into the device. So if, for some reason you choose a design that does not have this particular ability to keep the mouth a little bit closed, so then the use of these hooks for elastics, it will prevent the excessive opening on the oral appliance. So titration means adjustment, like moving the mandible further forward during the follow-ups, 0.5 millimeter, 1 millimeter. So this is what we're doing for titration. We're choosing a different band, and the length of the band is going to be shorter. So the shorter the band, the more protrusion you are going to obtain. And there is a number on the side of the band, so that will be easy to identify. So this adjustment can be done in the and the patient can be done this adjustment at home, or it's just depending on your protocol. So you prefer to do this adjustment in the office, the dental office, to have better control of the dimension, the amount of protrusion. So certainly that could be a good option. But I mean, here we can see the way the adjustment is done. It's straightforward, choosing a different band, the length is you need to choose a different color. Certainly you have variety of these bands. So the manufacturer provides a different set of bands for your patient. So this is another design that we see here. It also falls under the bilateral traction. So this bilateral traction design, so the attachment also goes, I mean, in this case from the middle, but from the upper part to the lower and the posterior area. So it comes in different lengths, this particular strap, but in general, the function is like a bilateral traction. So from the anterior area to the posterior, like pulling the mandible towards this particular part. So here we have a different view, just to maintain the mandible forward, and some figures of how to advance this particular device. And all these devices, as we mentioned, all these devices are adjustable. So the adjustability, it comes in 0.5 millimeter, 1 millimeter, so you can obtain different lengths on these sides. It's another design that utilizes this particular rods on each side, but also it falls under this category of bilateral traction design. So moving into the next category, the next nomenclature. So we already completed the bilateral compression, bilateral tractions. So now we're looking into this midline traction design. So the midline traction design, as we see here, so the component is mainly in the middle, the anterior area, and it's a hook light. So there is some component that will provide the adjustability. It will move the mandible forward, and it will place the hook between the upper plate and the lower plate, and we can see the key over here on the right side that it will provide the adjustment. So here we have a better view, okay? And Frank, what can you tell us about this particular design, the midline traction?
Yes, Doctor. So this happens to be the Dream Tap, and the nice thing about it is you mentioned using elastics and hooks to help to keep the mandible closed. Well, by design, this device it creates that relationship where it's the same components that are allow you to advance the mandible also help to keep the mandible closed. So hopefully to help to promote nasal breathing. The Dream Tap specifically has the components on the lower arch, so it allows for more tongue space on the maxilla, for the proper posturing of the tongue. And yeah, it's a really great device, and it's also again for those of you that take care of Medicare patients, this is covered by Medicare.
Yeah, so and actually this is a good example that we were talking about the previous design, regarding the excessive range of opening. So when you're looking for something to prevent excessive opening, so I mean, The options are the elastic, the hooks for elastics to prevent excessive opening, or an appliance design like this that certainly it will prevent the excessive opening during the sleep. So it's something to keep in mind when you are looking into these designs. So here we have the different views, and this is the same video that we just saw before. So from the midline traction, so now we are moving into the bilateral interlocking design. And this is the, from the category of the adjustable devices. So this is the last one. So we already reviewed bilateral compression, bilateral traction, midline traction. So now we're looking into the bilateral interlocking. So this bilateral interlocking, basically it includes these fins that are going to prevent for the lower plate or the mandible to move back, so we maintain the forward position. So there are different designs, though, different manufacturers that can provide this design, as we see here. Okay, opening and closing. All right, and then a good point though. So here we can see that this design, the bilateral interlocking though, so it goes into the upper and the lower plate. However, the mechanism, the component is not directly attached from the upper plate to the lower plate. So what does that mean? So what I'm trying to say is that this particular design, it will easily allow the patient to open. Okay, it's comfortable. The patient does not feel the restriction of keeping the mouth closed. However, so it's important to know that if the patient have a significant regional opening and you, for some reason, decide to fabricate this appliance, so it's important to request the hooks for elastics that are going to prevent this excessive opening. And I believe there is a space on the laboratory form that you need to include to be able to obtain the hook for elastics. So Frank, what can you tell about the share with to the colleagues watching this webinar about this bilateral interlocking design?
Doctor, there's a couple of little great things about this dorsal design, the bilateral interlocking. One of them is, of course, it can be used on virtually any patient that you choose for it. But if you have cases where there's very low retention, low undercut, or maybe the patient is missing several teeth, some of the device designs will not retain, will not hold position. So bilateral interlocking could be a really good choice. Here we have a couple different examples of it. This is a true dorsal acetal, which is extremely thin, the white one on the right side of your screen, and the other is a PMMA. So two very different materials. There are pros and cons to both. And of course, there's so many variations of this appliance design with different manufacturers. So whomever you work with, just know that it's a very versatile design that you can work with.
Thank you so much, Fran. Again, as Fran mentioned, so there is a variety of manufacturers, but we can see here different materials. But in fact, it's the concept, the nomenclature, the way that is going to interlock between the upper and the lower plate. And pretty much that is the main concept from this bilateral interlocking design. So now this one, by the way, we completed the 4 standard design for adjustable appliances: compression, traction, midline traction, and bilateral interlocking. And, I wanted to include this one because it's not commonly included or seen into the, the literature, but the tone retainer device is there, it exists. So it's prefabricated. And the main component or the main situation when this appliance is useful, is in patients with edentulous in process of getting extensive dental wall, waiting for, dental wall or so on, or as a temporary device. It's good to have this device handy and, something that you can easily place into the patient's mouth. So just to conclude this series of slides regarding oral appliances, So it's important to know that I think the next generation or the upcoming generation of devices, they will include some type of sensors, compliance sensors, maybe some nano sensors at some point, just to measure different parameters. The field of dental sleep medicine is constantly evolving, it's emerging, it's at a very fast pace. At the same thing, the designs of oral appliances, will have the ability to measure some parameters with these particular sensors or nanosensors that at some point we will see more often. So having said that, so something important to disclose or to discuss with the patient is along the use of the device, care of the device, is to keep the oral appliances away from pets. Okay, so they easily find the appliances, and they will smell the device, the saliva, and they love to chew the devices. Every year, I mean, we have at least, I think, at least three accidents though per year, when these devices unfortunately are found by the dogs, by the pets. So they love to chew these devices. So we want to thank you all for participating, for joining us in this webinar. I think the basic information or the basic message from this webinar is, if some of you are initiating, thinking to incorporate this treatment modality in your office, so it's important to know the steps of screening, collaboration with the local sleep doctor, sleep physician, ENT, sleep center, and to follow some particular protocols. There are some existing guidelines, some recommendations to, to initiate therapy, adjustment of the device as well, some protocols. But I think today's message was about understanding the mechanism, understanding the appliance design based on the nomenclature, the attachment and proportion, talking about bilateral traction, compression, midline traction, and bilateral interlocking. So this is my contact information. If some of you have, want to contact me directly, so feel free. So this is my contact. And I want to invite also for you to scan these QR codes. So there are two QR codes though. So this QR code is going to take you to the Tufts University website, Continuing Education. And the one on the left side is related to the dental sleep medicine in residency that is about to start. By the way, it will start next week. The first session is online. It's a hybrid program. So as you scan the QR code, so you will see the expanded information about the program. And the one on the right side is related to the TMD mini residency, also offered at Tufts University. So this TMD mini residency is pretty much offered by the Craniofacial Pain Center. Faculty from the Craniofacial Pain Center are the main instructors, and we provide guidance towards the program. We select, from the main group. We develop small teams, and a faculty member is assigned to this particular team that will guide the group towards the whole program. So I invite you to scan, take a picture, and it will take you to the website from Tufts University Continuing Education, where they can you can call and they can provide some additional information about these particular mini residency programs offered at Tufts University. So having said that, I'm going to pass the slides to Trish and Frank to finalize this session and to go over some additional information.
Thank you, Dr. Correa. We appreciate you. Thank you.
Yes, thank you. We'll give everyone a few more moments to put some questions. I see there's some questions in the questions box. So take the next couple minutes to put your questions in there, and we'll address them here shortly with Dr. Correa. So thank you all, of course, for joining us this evening. We are offering a special here for everyone that attended the course. The promo this month is 20% off your milled PMMA True Dorsal Appliance, and that is going to be good until September 30th. So if you get those cases into us by then, go ahead and use the promo code on the screen and you can get that discount. If you're not a True Function client and you would like to be, feel free to click the new account form in the chat box and get started sending cases to us or asking any questions that you may need. So we invite you to joining us as well on social media where we do webinar updates, or we post our specials and also tech tips. So it's a great way to get great resources when working with True Function. Our next webinar is going to be on Wednesday, October 25th, and that is going to be featuring Awaken to Sleep. The title is going to be Converting Consults to Cases, the Art of Treatment Planning. So we'd love to have you joining us for that. I'll go ahead and put the link for that in the chat box as well while we're answering questions. So we hope we'll see you there. Also, if you have any topics for us in the future, feel free to put those in the chat box as well. We're happy to cover those if there's anything specific that you're wanting questions about. We'll be emailing out the recording for this webinar after the webinar. Give us a day or so. So look for that in your email if you want to go back and review any of the information from today. So go ahead and put those questions in the question box. If you have any questions, you can also raise your hand with the raise your hand option in the bottom toolbar, and that'll allow me to unmute you so that you can ask those questions to Dr. Correa or Frank.
Wonderful.
So the first question here is, what are the pros and cons of acetyl versus PMMA?
Yes, PMMA is standard acrylic, so it's a polymethyl methacrylate. The difference with the PMMA that we're using specifically for these devices is it's a milled, so it comes in a clear puck, looks like glass basically. So the device, can be repaired, can be relined, adjusted, like acrylic. It polishes beautifully, looks like glass. It's stronger than traditional acrylic. It's very dense. Now, PMMA is, acetyl is a semi-rigid resin, so it's flexible. It's made at about 1 millimeter thick. The tray is, so the device allows for a lot more tongue space, and it's very strong and fracture resistant. I haven't seen a device break yet. The downside to acetyl is that you cannot bond, you cannot repair it, so it's something to consider. But if you have a patient that's a heavy bruxer, acetyl could be a really, really good option, not just for a sleep device, but for a splint or a night guard.